At what point do you take them off the antiarrhythmic after they still are an AFib and they can't maintain, again, sinus rhythm?
I started using amiodarone in 1970, so I've been using it in thousands of patients for over 4 decades. And I've learned how enormously variable it is as far as blood levels. Let's say you admit someone they're on amiodarone and they're an AFib. The first thing I would do is get a blood level. If their amio blood level, let's say, is zero point 0.9, zero point 0.8, I would give them an amio load, usually something anywhere from maybe 3 to 400 milligrams a day for 2 or 3 weeks, and then reassess. Because if you get the level up to 1.5 or 1.6 or 7, somewhere around there, and you still can't keep them in sinus, then it's time to call it a day. I mean, it's just not working. You have to accept that fact and go on to something else. Now, they could still be an ablation candidate. There's no other antiarrhythmic drug I tried. It is the most effective antiarrhythmic drug, but you could still be a potential ablation success. If, in other words, if the patient was very symptomatic in AFib and you're feeling like, oh, my goodness, I really want to help this patient, well, then maybe you pivot to a more aggressive approach. That's a person that might benefit from even hybrid therapy. So, for example, you do an ablation and they go back in AFib, but not uncommonly after you've done an ablation, antiarrhythmic drugs work where they didn't before. The way I explain that to patients is imagine you can't lift 100 pounds of weight, but now I give you 25 pounds and it's a piece of cake. You lift that. Well, it's kind of the same way in a sense. I know it's a simple analogy, but if you go in there and you wall off the veins and you do a few other things, and then they still come back in AFib, there are not as many areas that could promote AFib anymore. And now an antiarrhythmic drug that failed previously can work really, really well. And I do that all the time with dofetilide. That's one of my favorite combos. I have a whole bunch of patients who've had an ablation, had a recurrence of AFib, and they got on dofetilide. I've been monitoring them for years, and they haven't had a recurrence. So there are ways, if you're savvy, a therapist, to get around those problems. So the question, Hannah, you have to ask is, why are they failing? Are they failing because the drug's just not working anymore? That's because there's been a change in the atrial substrate in those situations. But before you make that call, you need to get a blood level because it's also possible the metabolism of it's changed. In a low blood level situation, I bump up the amio and then I recardivert them and see how they do. That's the way I handle that situation. But if their blood level is low, I wouldn't cardivert them because you're just going to go back out of rhythm. Before doing that, I would just give them an outpatient load of amio and then cardivert them because otherwise they're going to go right back out. There's no reason to think that they'll stay in sinus rhythm if their blood level's low. But I will tell you this. Here's what's going to commonly happen to y'all. You're going to have a patient who's done well on a drug for a number of years. Let's take flecainide or even dofetilide, 4, 5, 6 years. And then suddenly it fails. They're having episodes of AFib. Most patients think something's happened with the drug. That's typically to say the drug's not working anymore, Dr. P. It's not working. Yeah, it's not working because something's happened in you. And it's almost always an anatomy problem. The patient is going through the natural progression of maybe developing some fibrosis or aging or whatever takes place. And now they're in a different state of their disease. So I wouldn't get any kind of levels with those drugs. But amio, it is worth it because amio is usually your last line before you do something else, right? So before you give up on amio, you want to make sure they had a good plasma level, or you're really sort of giving up on a drug that maybe could still be useful.
And in those patients too, when you're trying to determine if it's a change in substrate, would you ever get a cardiac MRI and evaluate for changes in their atria, or do you just kind of keep going, trialing different drugs and different cardioversion therapies, and at the end of the day, if they don't work, you just presume that they had some changes to their
That's a
atria?
very good point. I don't get cardiac MRIs, but I do get echoes. So what I'll do is I will get a repeat echo at that point, and I'll look at strain in the atrium. I'll take a look at volume index, all those things, and then go back and look at how it was maybe 3, 4 years ago.